This is Chapter 14, Psychological Disorders. In this chapter, we will take a look at what it means to have a mental disorder. We'll define and classify disorders. We'll take a look at anxiety disorders, including generalized anxiety disorder, panic disorder, phobias, obsessive-compulsive disorder, and post-traumatic stress syndrome. We'll also explore mood disorders, including depression and bipolar disorder, schizophrenia, and samples of other disorders, including dissociative disorders, eating disorders, and personality disorders. We'll also explore the rates of diagnosis with disorders. And first, let's take a look at why it's important to learn about disorders. Some reasons for curiosity include personal familiarity with psychological symptoms, knowing someone else with a disorder, hearing about how prevalent and socially devastating some disorders have become in society, wanting to learn more about mental health and human nature. And here are some perspectives on psychological disorders. Defining psychological disorders, thinking critically about ADHD, understanding psychological disorders, classifying psychological disorders, labeling psychological disorders, insanity and responsibility, and some questions to keep in mind. How do we decide when a set of symptoms are severe enough to be called a disorder that needs treatment? Can we define specific disorders clearly enough so that we know we can be sure that we're referring to the same behavior or mental state? And can we use our diagnostic labels to guide treatment rather than to stigmatize people? So a psychological disorder is a significant dysfunction in an individual's cognitions, emotions, or behaviors. Disorders are diagnosed when there is dysfunction, behaviors which are considered maladaptive because they interfere with one's daily life. Disorders are diagnosed when the symptoms and behaviors are accompanied by distress or suffering. The new definition, a disturbance in the psychological, biological, or developmental processes underlying mental functioning. So they give us an example here of ADHD, or attention deficit hyperactivity disorder. ADHD is defined as impulsivity mixed with inattention and/or hyperactivity. It can include distractibility, disorganization, fidgeting, difficulty suppressing impulses, and impaired working memory. So we explore now whether or not this is a disorder using that definition. So is it deviant? Do some people have a level of inattentiveness, impulsiveness, or restlessness that goes beyond laziness or immaturity? Is it distressful? Is the person enjoying being energetic, or are they frustrated that they can't sustain focus? And is there dysfunction? Are the symptoms harmless, fun, or do they negatively impact work and relationships? And obviously we've decided that in the case of ADHD, all of those things are true and it is classified as a disorder. So taking a look now at the origins of identifying and treating psychological disorders. One reason to diagnose a disorder is to make decisions about treating the problem. And based on older understanding of psychological disorders, treatments have included exorcising evil spirits, beatings, caging and restraint, and the good old screw to the head, okay? So in the 18th, 19th century, Philip Pinel proposed that mental disorders were not caused by demonic possession, but by stress and inhumane conditions. Pinel's moral treatment involved gentleness, nature, and social interaction. His interventions improved lives, but often did not effectively treat mental illness. Then there was the discovery that the disease of syphilis caused mental symptoms by infecting the brain, which suggested a medical model for mental illness. Under the medical model, psychological disorders can be seen as psychopathology or an illness of the mind. Disorders can be diagnosed, labeled as a collection of symptoms that tend to go together, and people with disorders can be treated, attended to, given therapy, all with the goal of restoring mental health. Taking a biopsychosocial approach to psychological disorder, some biological influences include evolution, individual genes, brain structure, and chemistry. Some psychological influences include stress, trauma, learned helplessness, mood-related perceptions and memories. And social cultural influences include roles, expectations, and definitions of normality and disorder. Culture also influences disorders. Culture-bound syndromes are disorders which only seem to exist within certain cultures. They demonstrate how culture can play a role in both causing and defining a disorder. Some examples include bulimia nervosa in the US, running amok in Malaysia, and hikikomori in Japan. We'll explore now classifying psychological disorders. So why create classifications of mental illness? And what is the value of talking about diagnoses instead of just talking about individuals? 1. Diagnoses create a verbal shorthand for referring to a list of associated symptoms. And 2. Diagnoses allow us to statistically study many similar cases, learning to predict outcomes. Finally, diagnoses can guide treatment choices. The Diagnostic and Statistical Manual makes it easier to count cases of autism spectrum disorder if we have a clear definition. They give us versions here. The most recent is the DSM-5. The DSM is used to justify payment for treatment, and it's consistent with diagnoses used by medical doctors worldwide. And here's a glimpse at some of the categories of diagnoses. Some critiques of diagnosing with the DSM is that the DSM calls too many people disordered. Also that the border between diagnoses or between disorder and normal seem arbitrary. Decisions about what is a disorder seem to include value judgments. Is depression necessarily deviant, for example? And diagnostic labels direct how we view and interpret the world, telling us which behavior and mental states to see as disordered. Many people think a diagnostic label means being seen as tainted, weak, and weird. However, these negative views and stigma come from popular cultural views of mental illness and not from the DSM. The DSM may contain the information to correct inaccurate perceptions of mental illness. We'll take a look now at insanity and responsibility. This is Jared Loughner, who shot many people, including a U.S. representative, in 2011. Loughner had schizophrenia and substance abuse problems, a combination associated with increased violence. So the question that we ask is, to what degree, if any, should he be held responsible for his actions? And these are some things you can take some time to think about yourself, and especially after exploring the information in this chapter. And what's the appropriate consequence? We'll look first at anxiety disorders, our self-protective risk reduction instincts in overdrive. We'll explore generalized anxiety disorder, panic disorder, phobias, obsessive compulsive disorder, post-traumatic stress disorder, and then the causes of anxiety disorders. Generalized anxiety disorder includes emotional cognitive symptoms such as worrying, having anxious feelings and thoughts about many subjects, and sometimes free-floating anxiety with no attachment to any subject. Anxious anticipation interferes with concentration. Physical symptoms include autonomic arousal, trembling, sweating, fidgeting, agitation, and sleep disruption. A panic attack is not just an anxiety attack. It may include many minutes of intense dread or terror, chest pains, choking, numbness, or other frightening physical sensations, a feeling of a need to escape. And panic disorder refers to repeated and unexpected panic attacks, as well as a fear of the next attack. A specific phobia is more than just a strong fear or dislike. A specific phobia is diagnosed when there is an uncontrollable, irrational, intense desire to avoid the same object or situation. Even an image of the object can trigger a reaction. The uncontrollable, irrational, intense desire to avoid the object of the phobia. To give us an example here of some fears and phobias and their rates. Some other phobias include agoraphobia and social phobia. We'll take a look at obsessive compulsive disorder now. Obsessions are intense, unwanted worries, ideas, and images that repeatedly pop up in the mind. A compulsion is a repeatedly strong feeling of needing to carry out an action, even though it doesn't feel like it makes sense. When is it a disorder? When there's distress, you're deeply frustrated with not being able to control the behaviors. Or when there's dysfunction, when the time and mental energy spent on these thoughts and behaviors interfere with everyday life. Some common OCD behaviors include The obsessions that are concerned with dirt, germs, or toxins, something terrible happening, or symmetry, order, and exactness. And the compulsions of excessive hand washing, bathing, toothbrushing, or grooming, repeating rituals, checking doors, locks, appliances, car brakes, and homework. A common pattern in OCD is rechecking. Although you know that you've already made sure the door is locked, you feel that you must check it again and again. Post-traumatic stress disorder affects about 10 to 35% of people who experience trauma. And it includes repeated intrusive recall of those memories, nightmares and other re-experiencing, social withdrawal phobic avoidance, jumpy anxiety or hypervigilance, insomnia or sleep problems. People who are more likely to develop post-traumatic stress disorder are those with sensitive emotion processing limbic systems, those who are asked to relive their trauma as they report it, and those previously traumatized. All right, so we'll take a look now at understanding anxiety from different perspectives. From a genetic perspective, we might be predisposed to some fears. From the perspective of learning and classical conditioning in particular, overgeneralizing a conditioned response could explain anxiety. From the perspective of learning again, but now from operant conditioning, there is reward and avoidance. Looking at the brain from a neuropsychological perspective, active anxiety pathways. Cognitive appraisal perspective, uncertainty may be linked to danger. And then from the natural selection perspective, we survive by avoiding danger. So these are just some ways to look at why we might develop anxiety. All right, we'll look at classical conditioning and anxiety and operant conditioning and anxiety. In the experiment by Watson in 1920, little Albert learned to feel fear around a rabbit because he had been conditioned to associate the bunny with a loud, scary noise. Sometimes such a conditioned response becomes overgeneralized. We may begin to fear all animals, everything fluffy, all experimenters. The result is a phobia or generalized anxiety. Looking at operant conditioning, we may feel anxious in a situation and make a decision to leave. This makes us feel better, and our anxious avoidance was just reinforced. If we know we have locked a door but feel anxious and compelled to recheck, rechecking will help us temporarily feel better. The result is an increase in anxious thoughts and behaviors. Taking a look now at observational learning and anxiety. Experiments with humans and monkeys show that anxiety can be acquired through observational learning. If you see someone else avoiding or fearing some object or creature, you might pick up that fear and adopt it, even after the original scared person is not around. And this way, fear gets passed down in families. Looking at cognition and anxiety, cognition includes worried thoughts as well as interpretations, appraisals, beliefs, predictions, and ruminations. Cognition includes mental habits such as hypervigilance, persistently watching out for danger, and this accompanies anxiety and post-traumatic stress disorder. In anxiety disorders, such cognitions appear repeatedly and make anxiety worse. We'll look at how biology and genes affect anxiety. Studies show that identical twins, even raised separately, develop similar phobias, more similar than two unrelated people. And some people seem to have an inborn high-strung temperament, while others are more easygoing. Temperament may be encoded in our genes. Genes regulate levels of neurotransmitters, and people with anxiety have problems with the gene associated with levels of serotonin, a neurotransmitter involved in regulating sleep and mood. People with anxiety also have a gene that triggers high levels of glutamate, an excitatory neurotransmitter involved in the brain's alarm centers. Traumatic experiences can burn fear circuits into the amygdala, and these circuits are later triggered and activated. Anxiety, obsessive-compulsive, and trauma-stress-related disorders include over-arousal of brain areas involved in impulse control and habitual behaviors. We see here the picture of a brain of someone who has obsessive-compulsive disorder, and we can see extra activity in the anterior cingulate gyrus. From an evolutionary perspective, Psychologists believe that ancestors prone to fear, the items on list number 1, were less likely to die before reproducing. And for list number 3, the theory is that there hasn't been enough time for the innate fear to spread in the population. We'll explore mood disorders now. These are not just feeling down and not just feeling sad about something. We'll look at major depressive disorder, bipolar disorder, explore the prevalence and course of depression, the genetic influences on depression, suicide and self-injury, negative moods and negative thoughts, and the vicious cycle. So major depressive disorder is more than just feeling down, more than just feeling sad about something. Bipolar disorder is more than mood swings, and depression plus the problematic overly up mood called mania. The criteria of major depressive disorders include having depressed mood most of the day and/or markedly diminished interest or pleasure in activities. In addition to these two, 3 or more of the following have to be present: significant increase or decrease in appetite or weight, insomnia, sleeping too much or disrupted sleep, lethargy or physical agitation, fatigue or loss of energy nearly every day, worthlessness or excessive inappropriate guilt, daily problems in thinking, concentrating, and/or making decisions, and recurring thoughts of death and suicide. Depression shows up in people seeking treatment. Phobias are the most common, frequently experienced disorder, but depression is the #1 reason people seek mental health services. It appears worldwide. Per year, depressive episodes happen about 6% of men and about 9% of women. And over the course of a lifetime, 12% of Canadians and 17% of USA residents experience depression. It's often referred to as the common cold of mental health disorders. Although both are common, occurring frequently and pervasively, comparing depression to a cold doesn't work. Depression is more dangerous because of suicide risk. It has fewer observable symptoms. It's more lasting than a cold and is less likely to go away just with time. It's much less contagious, and depressive pain is beyond sniffles. Seasonal affective disorder is more than simply disliking winter. Seasonal affective disorder involves a recurring seasonal pattern of depression, usually during winter's short, dark, cold days. They give us an example of a survey asking, "Have you cried today?" The result was that more people answered yes in winter. We'll look at bipolar disorder now. Bipolar disorder was once called manic depressive disorder, and the disorder's 2 polar opposite moods are depression and mania. Mania refers to a period of hyper-elevated mood that is euphoric, giddy, easily irritated, hyperactive, impulsive, overly optimistic, and even grandiose. Depressed mood, again, stuck, feeling down, includes those symptoms that we talked about earlier. In addition to exaggerated pessimism, social withdrawal, lack of felt pleasure, inactivity and no initiative, difficulty focusing, fatigue, and excessive desire to sleep. On the other hand, mania, that euphoric, giddy, easily irritated state, includes exaggerated optimism, hypersociality and sexuality, delight in everything, impulsivity and overactivity, racing thoughts, and little desire for sleep. Many famous and successful people have lived with the ups and downs of bipolar disorder. Some speculate that the depressive periods gave them ideas, and the manic episodes gave them creative energy. So they asked, does bipolar disorder show up before adulthood and even before puberty? Many young people have cycles from depression to extended rage rather than mania. The DSM-5 has added a new diagnosis for some of these kids: disruptive mood dysregulation disorder. So why are mood disorders so pervasive among women? Women starting in adolescence appear to ruminate more, have deeper sadness than men, encounter more stressors, and report their depression more readily. So why does depression often go away on its own? What is the course or development of reactive depression? often time heals a mood disorder, especially when the mood issue is in reaction to a stressful event. However, a significant proportion of people with major depressive disorder do not automatically or easily get better with time. We'll look now at some biological explanations, also some social cognitive aspects. So first, looking at the biology of depression. Depression in its milder and non-disordered form may have had survival value. Under stress, depression is social-emotional hibernation. It allows humans to conserve energy, avoid conflicts and other risks, let go of unattainable goals, take time to contemplate. And evidence of the genetic influence on depression includes DNA linkage analysis that reveals depressed gene regions and twin adoption heritability studies. Brain activity is diminished in depression and increased in mania. The smaller frontal lobes in depression and fewer axons in bipolar disorder show that there's also brain structure differences. There are more norepinephrine arousing neurotransmitters in mania and less in depression. And in depression, there's a reduction of serotonin neurotransmitters. We'll look now at suicide and self-injury. Every year, 1 million people commit suicide, giving up on the process of trying to cope and improve their emotional well-being. This can happen when people feel frustrated, trapped, isolated, ineffective, and see no end to these feelings. Non-suicidal self-injury has other functions such as sending a message, distracting from emotional pain, giving oneself permission to feel, or self-punishment. So we'll look now at depression from a social cognitive perspective. So it's associated with low self-esteem, learned helplessness, and rumination. Low self-esteem can manifest as discounting positive information and assuming the worst about oneself, situation, or the future. Learned helplessness can include self-defeating beliefs, such as assuming that oneself is unable to cope, improve, achieve, or be happy. And rumination includes stuck focus on what's bad. We'll explore also a depressive explanatory style. So how we analyze bad news will predict our mood. They give us an example of breaking up with a romantic partner. If we assume the problem is stable, we might think, I'll never get over this. If, however, we assume that the problem is temporary, we might think, this is hard to take, but I will get through this. If we assume the problem is global, we might think, without my partner, I can't seem to do anything right. But if we assume the problem is specific, we might say, I miss my partner, but thankfully I have family and other friends. If we assume the problem is internal, then we might say, it's all my fault. If, however, we see it as external, we might acknowledge that it takes two to make a relationship work and it wasn't meant to be. The ending result is that if we see the problem as stable, global, and internal, we will feel depressed. If, however, we see the problem as temporary, specific, and external, then we will have successful coping. Notice that this doesn't mean that we don't experience the negative mood states or the pain that's associated with any challenge in life. But what it does mean is that we acknowledge that we are able to move through it instead of being stuck by it. So I take a look now at the vicious cycle that depression creates. At number one, they have a stressful experience, but what is much more accurate is that we have an experience that we perceive as stressful, and there is a very big difference there. Hopefully that's clear from the perception chapter, but the idea is that it's not the event, it's the way that we perceive the event. So if we perceive something as being stressful or not manageable, then that leads to us having an explanatory style about it. If our explanatory style is negative, as we explored in the previous slide, then that turns into a depressed mood. That depressed mood creates cognitive and behavioral changes, and those cognitive and behavioral changes then again contribute to our perceiving events as stressful, and then the cycle begins again and again and again. We'll take a look now at schizophrenia. We'll look at the symptoms, and we'll look at the causes of symptoms. So in schizophrenia, the mind is split from reality. For example, a split from one's own thoughts so that they appear as hallucinations. Psychosis refers to a mental split from reality and rationality. Schizophrenia symptoms include disorganized and/or delusional thinking, disturbed perceptions, and diminished and inappropriate emotions. Symptoms for schizophrenia can be positive or negative. Positive means the presence of problematic behaviors, and negative refers to the absence of healthy behaviors. Positive symptoms include hallucinations, illusory perceptions, especially auditory, delusions, illusory beliefs, especially persecutory, and disorganized thought and nonsensical speech, including bizarre behaviors. Negative symptoms include flat affect, no emotion showing in the face, and reduced social interaction. It also includes anhedonia, no feeling of enjoyment, avolition, less motivation, initiative, focus, and tasks, alogia, speaking less, and catatonia, moving less. We'll explore the symptoms that include problems in thinking and speaking. Disorganized speech includes the word salad of loosely associated phrases. Delusions, again, are often bizarre and not just mistaken. The most common are delusions of grandeur and of persecution. Problems with selective attention, including difficulty filtering thoughts and choosing which thoughts to believe and to say out loud. Disturbed perceptions. People with schizophrenia often experience hallucinations. That means perceptual experiences that are not shared by others. So very simply, we're talking about people seeing or hearing things that others don't see or hear. The most common form of hallucination is hearing voices that no one else hears, often with upsetting or shaming content. Hallucinations can also be visual or olfactory, tactile, or taste. Schizophrenic symptoms also include inappropriate emotions and actions, so odd and socially inappropriate responses, such as looking bored or amused while hearing of a death. Again, that flat affect, facial or body expression is flat with no visible emotional content. Impaired perception of emotions, including not reading others' intentions and feelings. And the schizophrenic body exhibits symptoms such as repetitive behaviors such as rocking and rubbing, catatonia, such as sitting motionless and unresponsive for hours. And we'll look now at the onset and development of schizophrenia. Typically, schizophrenic symptoms appear at the end of adolescence and in early adulthood. This is later for women than for men. Nearly 1 in 100 people develop schizophrenia, and it's slightly more men than women. And the course of schizophrenia can be acute or reactive or chronic. So acute reactive refers to in reaction to stress, some people develop positive symptoms such as hallucinations. Recovery is likely. For chronic process, development is slow, but with more negative symptoms. With treatment and support, there may be periods of a normal life, but not a cure. And without treatment, this type of schizophrenia often leads to poverty and social problems. So what's going on in the brain in schizophrenia? Abnormal brain structure and activity is found. So there are too many dopamine receptors that help to explain paranoia and hallucinations. It's like taking amphetamine overdoses all the time. There's poor coordination of neural firing in the frontal lobes, which impairs judgment and self-control. And the thalamus fires during hallucinations as if real sensations were being received. There is general shrinking of many brain areas and connections between them. Are there biological risk factors affecting early development? Schizophrenia is somewhat more likely to develop when one or more of these factors is present. Low birth weight, maternal diabetes, older paternal age, famine, oxygen deprivation during delivery, or maternal virus during mid-pregnancy impairing brain development. It's more likely to develop in babies born during and after flu epidemics in densely populated areas, a few months after flu season, after mothers had the flu during the second trimester or had antibodies showing viral infection. The lesson is to get flu shots with early fall pregnancies. Are there genetic risk factors? If so, we would see more similar schizophrenia risk shared between identical twins than fraternal twins. So take a look at this graph and see if that's what you see. If one twin has schizophrenia, the chance of the other one also having it are much greater if the twins are identical. Having adoptive siblings or parents with schizophrenia does not increase the likelihood of developing schizophrenia. So some genetic and prenatal causes. Even in quadruplets, genetics do not fully predict schizophrenia. This could be because of environmental differences. First difference, twins and separate placentas. So only one of two twins has the enlarged ventricles that are seen in schizophrenia. Take a look now at some other disorders, including dissociative personality and eating disorders. Dissociative disorders are a separation of conscious awareness from thoughts, memory, bodily sensations, feelings, or even from identity. Dissociative disorder is dysfunction and distress caused by chronic and severe dissociation. Some examples are dissociative fugue state, dissociative identity disorder, which is previously referred to as multiple personality disorder. So in dissociative fugue state, or running away, there's wandering away from one's life, memory, and identity with no memory of them. In dissociative identity disorder, there's the development of separate personalities. In the rare actual cases of dissociative identity disorder, the personalities are distinct and not present in consciousness at the same time. They may or may not appear to be aware of each other. Some alternative explanations for dissociative identity disorder are that dissociative identities might just be an extreme form of role-playing. In North America, dissociative identity disorder might be a recent cultural construction, similar to the idea of being possessed by evil spirits. Cases of dissociative identity disorder might be created or worsened by therapists encouraging people to think of different parts of themselves. Some evidence that dissociative identity disorder is real, however, does exist. Different personalities have involved different brainwave patterns, different left-right-handedness, different visual acuity and eye muscle balance patterns. And patients with dissociative identity disorder also show heightened activity in areas of the brain associated with managing and inhibiting traumatic memories. Explaining fragmentation of personality from different perspectives. From the psychoanalytic perspective, diverting the id. From the cognitive perspective, coping with abuse. From the learning perspective, dissociation pays. And from the social influence perspective, therapists encourage. We'll look now at eating disorders, specifically anorexia nervosa, bulimia nervosa, and binge eating disorder. So these may involve unrealistic body image and extreme body ideal, a desire to control food in the body when one's situation can't be controlled, and cycles of depression, including health problems. Anorexia nervosa is defined as compulsion to lose weight, coupled with certainty about being fat despite being 15% or more underweight. The prevalence is about 0.6%. Bulimia nervosa is defined as compulsion to binge, eating large amounts of food fast, then purge by losing the food through vomiting, laxatives, or extreme exercise. The prevalence is about 1%. Binge eating disorder is defined as a compulsion to binge, followed by guilt and depression, and the prevalence is about 2.8%. Some family factors that contribute to eating disorders: having a mother focused on her weight and on the child's appearance and weight, negative self-evaluation in the family. For bulimia, if childhood obesity runs in the family. For anorexia, if families are competitive, high-achieving, and protective. And cultural factors include unrealistic ideals of body appearance. We'll look now at personality disorders. Personality disorders are enduring patterns of social and other behavior that impair social functioning. There are three clusters or categories of personality disorders: anxious, eccentric, odd, and dramatic. Anxious, for example, avoidant personality disorder, includes being ruled by fear of social rejection. Eccentric or odd, for example, schizoid personality disorder, includes flat affect and no social attachments. And dramatic, for example, histrionic, includes attention-seeking behaviors, narcissistic, self-centered, and antisocial or amoral thoughts and actions. So we'll look at antisocial personality disorder. It is persistently acting without a sense of guilt for harm done to others, strangers, and family alike. The diagnostic criteria include a pattern of violating the rights of others since age 15, including three of these: deceitfulness, disregard for safety of self or others, aggressiveness, failure to conform to social norms, lack of remorse, impulsivity, and failure to plan ahead, irritability, irresponsibility regarding jobs, family, and money. So which kids may develop antisocial personality disorder as adults? About half of children with persistent antisocial behavior develop lifelong antisocial personality disorder. Which kids are at risk? Some psychological factors: those who in preschool were impulsive, uninhibited, unconcerned with social rewards, and low in anxiety. Those who endured child abuse and or inconsistent, unavailable caretaking. Some biological risk factors: antisocial or unemotional biological relatives increases risk. Some associated genes have been identified. Lower levels of stress hormones and low physiological arousal in stressful situations. Fear conditioning is impaired. And reduced prefrontal cortex tissue leads to impulsivity. Substance dependence is also more likely. We're looking now at how antisocial personality disorder matches up with criminality. So criminals are people who repeatedly commit crimes, and people with antisocial personality disorders are those that fit the criteria we previously mentioned. Many career criminals do show empathy and selflessness with family and friends. Many people with antisocial personality disorder do not commit crimes. So there is some overlap here, but they are not automatic. Though antisocial personality disorder is not a full picture of most criminal activity, what can we say about people who commit crime, especially violent crime? Lower levels of physiological arousal, measured here as adrenaline levels, under stress may enable taking violent action without feeling anxiety or panic. People who commit murder seem to have less tissue and activity in the part of the brain that suppresses impulses. Some other differences include less amygdala response when viewing violence, and an overactive dopamine reward-seeking system. So this is a chart exploring how common psychological disorders are. Countries vary greatly in the percentage of people reporting mental health issues over the past year, and this is for 2004. This list takes a closer look at the past year prevalence of various mental health diagnoses in the United States. And they're referring to past year here, but this is for 2008. All right, so who is vulnerable to mental disorders? Poverty increases the risk of many mental disorders, including aggression and anxiety. Disorders decrease when poverty is lifted. The immigrant paradox refers to the fact that despite the stress of immigrating, those who immigrate to the USA have a lower risk of disorders than their children born in the USA. Again, looking at the cultural impact of mental health. Age of vulnerability. Many disorders begin to show symptoms by early adulthood and developing on average around age 20. Obsessive compulsive disorder, schizophrenia, bipolar, and alcohol use disorder are examples. Showing some signs earlier: phobias, the median age is 10, and antisocial personality disorder, some symptoms by age 8. And developing later than 20, major depressive disorder. So most disorders are going to manifest around 20, very few in childhood, and for depression, that's possible to be over 20. So there are risks to be watchful of, obstacles to be overcome, and improvements to be made, often with the help of treatment. Some people with psychological disorders do not recover, and some achieve greatness even with a psychological disorder. That's the end of Chapter 14, Psychological Disorders. If you haven't already, make sure that you jump into the chapter, complete your learning curves and chapter tests, and as always, if you have questions, make sure that you reach out to me.